Very good afternoon, ladies and gentlemen. This is Dr. Shudipta Mitro. For our next session, walking hand in hand on difficult roads to beautiful destinations. We've been doing this session for the last few years in AIOS or otherwise, and there's a theme behind this, that there are equal number of participants from either sex, male and female, who are going to talk, pair up to show their skills or expertise in a particular topic. Today we have 4 such topics with speakers, and with me is moderating Dr. Vedang Shah. So at the very beginning, let me call upon the chairpersons. I'm sorry, none of them are right now here because one is Dr. Partha Viswas sir, who's in the award ceremony, and Dr. Rutish Pal sir, who's in the other room where OSWB session is going on. It's just going to finish now. And the panelists, the esteemed panelist, Dr. Swaraj Bhattacharya sir. Sir, please come on stage. Dr. Salaf Sinha, Salaf. Dr. Chaitra, yes, please come on stage. Dr. Deepa Shaha, I think she's also in the other room. Dr. Aditi Ghosh Dastidar. Dr. Ghazal Patnaik, she's not here. Dr. Raj Shekhar. Dr. Raj Shekhar Pal. And Dr. Rohit Om Prakash will be joining us soon. So, not wasting much time, please come over, all the panelists. The chairpersons will join. Let us call upon the first pair of experts in a topic which is controversial, or maybe I should say a kick through for people like Dr. Manpreet Kaur and Dr. John Sharkar. DMEC or ultra thin dissec in PBK. All over to you. So who's coming first? You. Okay, Dr. Manpreet Kaur, it's all yours.
A very good afternoon to all of you. So we are not actually going to debate, we are going to present two perspectives on the same issue. So because we are supposed to be walking hand in hand, so my topic will be descemet membrane endothelial keratoplasty and pseudophakic bullous keratopathy. No financial disclosures. So just a case of a 61-year-old female with progressive diminution of vision post-cataract surgery, uncorrected distance visual acuity of 5/60, diagnosed with a pseudophakic corneal decompensation with a corneal thickness of 731 microns with bulle. Surgical options, of course, penetrating keratoplasty has been replaced by endothelial keratoplasty in cases where there is no central visual axis full thickness scarring. So we had the option of going ahead with a descemet stripping, automated or non-automated endothelial keratoplasty, or a descemet membrane endothelial keratoplasty. We went ahead with a descemet membrane endothelial keratoplasty. So this is the donor tissue preparation. Essential points: first, you do a partial trepanation with a 9.5 to 10 mm trephine. You have to stain with trypan blue dye. Choose the tissue which is at least 40 years of age or older, the donor. Remove all the peripheral adhesions before you start peeling. That is very important, otherwise you'll have a tear even if there is a filiform adhesion left. Then peel with a fine forceps in a single go. Various instruments are available. In this case I had a small peripheral tear while peeling from one side, so I redirected my peel so as to not put any further traction on that tear. After around 70-80% of peel is achieved, a stromal window is created with a 3 mm dermatomal punch. This is so that you can mark S or F, whatever letter suits your fancy. Reposit the DM, invert the cornea, and then dry this stromal window, and the stromal aspect of the descemets is marked with a letter so that you can assess the orientation intraoperatively. Stain at this point for a full 60 seconds at least, because you want that scroll to be visible intraoperatively. Then refine the final desired size, 7.5 to 8 depending on your white to white. Remove the peripheral descemets and complete the peel to remove the last 10% as well, and transfer it to a petri dish filled with BSS. So this is the donor preparation, which is simple once you have mastered the art of patience and releasing all peripheral adhesions. Coming to the actual surgery itself, step 1 is of course scoring the Descemet's after you have made your incisions, a main 2.2 and peripheral paracentesis incisions. You have to not go too deep, not create any further scarring or disturb the stroma too much. Usually the cases that are suitable for DMEC, the DMECable cases per se, the Descemet's comes out really easily when you are scoring with a reverse Sinski. You have to remove it en toto because any adhesion or small tag left behind will interfere with the attachment of the donor Descemet scroll. An IOCT is a useful guide at this stage to assess if you have completely removed the Descemet's or not. An inferior PI help because you do want a complete air fill to promote adhesion of that thin Descemet's membrane. Remove all OVD. Any residual OVD is going to hamper your adhesion. Then a glass pipette is used to load the graft and it's injected in a relatively shallow AC. So the trick in DMEC is the AC has to be shallow during all manipulation vis-a-vis a DSEC in which you want a deeper AC. Suture the main wound. This scroll is very, very tricky. It can exit even via paracentesis incisions. After that, it is a dance with the fluidics, and you have to use BSS cannulas to center and to see the orientation. Right now it is reversed, so I'm injecting BSS. OCT of course is invaluable at this time to assess the orientation. So fluid injections can help you reverse the graft in case it is upside down. So right now it's in the correct orientation. Now we can center and move ahead with opening. So there's a well-attached graft on ASOCT, uncorrected distance visual acuity, 624 on day 1, and you can see the graft acting even on first day, improved to 6.9 at 2 weeks. So when you look at the 10-year outcomes of DMEC, DSEC and PK, DMEC and DSEC both have faster visual recovery, much faster in DMEC. PK has superior long-term graft survival. It's similar for DMEC and DSEC at 10 years. Endothelial cell density decreases significantly faster after DMEC and DSEC, and it is less in DMEC, 3% versus 8% in DSEC. DMEC demonstrates the lowest rejection rate. So when you compare the two, visual outcomes are comparable in ultra-thin DSEC and DMEC. There is a stringent inclusion criteria for DMEC, however it is more physiological, has a faster visual recovery, less endothelial rejection, and better long-term visual outcomes. Thank you for a patient hearing.
So, should I start? Very good afternoon to all of you. So, I am not differing or debating with Dr. Manpreet. I am a poor demic person. So now I am sharing my slides. So, these are the some of the special case scenario, and the answer is obviously the endothelial keratoplasty. So, what is my topic will be ultra-thin DSEC, whereas she has spoken about the DMEC, and ultra-thin DSEC is my new tech. So, what is ultra-thin DSEC? The normal conventional DSEC thickness is graft thickness 150 to 250 micron, whereas the thin DSEC graft is 100 to 149 micron. And what is the thickness of the ultra-thin DSEC? The thickness is 90 to 50 to 99 micron, and if it is less than 50, it's called nano-thin DSEC. So, I'm sharing one of the one-eyed patient who came to us for the PBK to how the graft preparation manually. So, sound please. So, it's 550 micron corneal thickness. We're making first diamond knife or 400 micron. Can I have a sound please? Then followed by, once I get the plane, this is special curved spatula of 90 micron customized or 15 degree by Georgia. I don't have any financial interest, but they customized the instrument for me. Is there? Yeah. So once it has been done, I first cut the first part. Up to that is like normal DSEC. Sure do. Cut it by the Vanna scissor. Now the second round of dissection started. It's a special 90 micron crescents. That's also customized by Georgia. And now here is very delicate. I'm just near to the Dovas layer, And once you get the plane, it's very easy by this spatula and like a peeling of the onion shell. And this is unedited video, so that much speed you can do it. Once it has been done, the handling of this graft is very delicate, with approximately 50 to 60 micron. It has a tendency for curl off. So normally what I used to do, the first button of the cornea, what is approximately 400 micron, use that button as a scaffold of the graft and enter this like a needle insertion technique with endothelium down and unfold it like this, and the wound is completed and wound is secure. So same thing, this is another patient, I'm not going into details. And what will be the outcome? This is the outcome of this patient. The one at patient, the graft thickness 44 micron, vision is 6 by 9, and after 1 month, what she was, Dr. Manpreet was telling, this patient having the 6 by 9 plano vision, and the specular count 1142. And this is another patient, same thing, same series, that also having the 6 by 9 vision. So what is the clinical implementation? The same thing we can be repeat these things in post-demic patient, and this is the outcome of that patient. So what is the outcome? Is the outcome on the rest of BCVA, surface quotient, and the corneal clarity and the happiness quotient. So what is the tech clinic message is that though the demic is the upcoming technique, but ultra-thin dissect is the equally good if it can be done correctly, specifically whenever you have done a standard backup, whenever you don't have the backup tissue. So you can do it equally, and it is equally outcome is good. So that's the tech clinic message. Thank you very much. These are some of the ultra-thin dissect post-op. Thank you.
Both of you have really given very insightful presentations. Thank you very much for that. Now over to our very young ophthalmologists here, Dr. Aditi Ghosh Dostidar and Dr. Rajshekhar Pal. Who would like to go first and discuss this for us? Dr. Rajshekhar?
Yes, ma'am.
Yes.
So as explained, both the DMEC as well as ultra thin DSEC, they both give equally good results. There have been some reports in the literature where they are saying that after a while the ultra thin gives a like the endothelial cell density, it decreases, or the visual acuity, but they have been non-significant, or most of the reports, as sir said, especially in our scenario where the tissues are scarce and when we don't have a backup tissue, this technique works well. And nowadays, even with the modern inserters like this Bucine, we have Bucine Glide, Macaluso inserters. No doubt sir is wonderful, he's doing with a needle itself, but for us, when we are starting and when we are doing this, and so the learning curve has also decreased with such inserters coming in place, and ultra thin is a lot easier, if not as difficult as in DMEC.
Okay. Aditi, your take on this?
Both were excellent. Ultra thin, yes, Rashik has already covered the pros, but I think like especially in cases when you want to plan 2 cases later on, so I would rather prefer DMEC because I'll have a very good upper layer and I can use it for DALs. And if I want ultra thin, it's similar to DMEC, but then we are taking off a lot of precious tissue. So that maybe in private practice that is a little bit, painful for us. But of course, I think we should opt for the surgery which we can give the best result to our patient in his or her condition with our hands. So both were excellent and both were absolutely correct.
Any inputs from the audience? I would request Dr. Rotishpal sir to please come and chair the session, come up on dais. And in interest of time, if Manpreet and John does not have anything to add on, we'll move on to the next topic. Okay, there's a little bit change of session. We would like to invite the next speakers, Dr. Manisha Agarwal and Dr. Shugoto Paul, to deal with secondary IOL. All over to you. Who's going first? Okay. How I sailed smoothly in recent times. All over to you.
So good evening everyone, and Sudipta, thank you so much for making me a part of this interesting session. Can we stop this? Because sound nahi aa raha as usual. शुरू से प्ले करिए. Okay, we'll forget about it अगर नहीं कर रहे हैं आप. So this is an aphakic patient who's been left aphakic after having undergone VR surgery. You are able to appreciate the inferior PI. Oh, sorry.
AV team, can we have the presentation, please?
I don't know. They're neither having the sound nor they're having the
Yeah.
video.
इस पे नहीं जाएगा उस
So this is a patient who's been left aphakic after a VR surgery. You can appreciate the inferior PI. So what I have planned for this particular patient is a CT flex IOL. It's already a vitrectomized eye, so I don't really need to do any kind of a anterior vitrectomy. So I place my sclerotomy at 3 and 9 o'clock after making the scleral flaps. So this patient apparently had a posterior dislocated IOL. So the IOL is lifted up and is delivered out through a limbal section. And why we could not place this IOL back? Because it had a broken haptic. So it had to be replaced with a new IOL, and this is a CT flex IOL that you can see. So I use these sclerotomy ports to get my IOL haptic out. And this beautifully tucks into a 23 gauge sclerotomy site. The same is again done on the other side. And the advantage of this lens is there's absolutely no question of decentration. So you can be very comfortable in putting in this IOL. This is another patient having an entire capsular bag with the IOL which has gone back. So this is lifted up again. And it's delivered out through a handshake technique. Because the capsular bag is all thickened, I decided not to resuture this particular IOL in place. So a section is made and this is delivered out. And here we decide to do a scleral fixated IOL. So the scleral flaps, they are made on either side. the haptics is taken out and it is going to be subsequently tucked in the scleral pockets. So I just wanted to show these two techniques of secondary IOL implantation.
So thank you, ma'am. So I'll be sharing my technique, what I normally do. As you all know, there are several types of secondary IOLs: scleral fixated, sulcus IOL, iris clip. Oh,
Slides, please.
so we are short of time.
Yeah, we can see them.
Yeah. So there are several types of secondary IOL techniques: scleral fixated, sulcus IOL, iris clip, AC IOL. All of them works well if vitrectomy is done in the right way. And iris clip has gained recently popularity because it's simple, fast technique, favorable function outcome, and is quite safe. So I saw one of the retinal surgeon, one of the very high volume retinal surgeon, instead of doing secondary IOL in the older way, he is doing the iris clip IOL shared by Dr. Subijay Sinha. So I thought, okay, I might try this, and this is the lens I normally use. What? Time ho jayega. So this is the lens I use. Now it's got stuck. It's got stuck now. So this lens has a diameter of 5.5, so you have to make the section 5.5 millimeter or 6 millimeter, and the length is 8 millimeter. And biometry calculation is 117.2. And this is my technique, what I am doing. This is a aphakia 1 month back. After 1 month, I have taken it off for secondary IOL. So you separate the conjunctiva and do a SICS section. You can also do a corneal section, but in that you have to put stitches. So I preferred SICS section after separating the cornea, conjunctiva, and doing adequate cautery. You do the section. So section is basically the SICS section, which I'm not very good doing that, but still as long as it's self-sealing, that will work. And once you have done the section, you fill the anterior chamber with visco. The vitrectomy was properly done previously, and you can see the pupil is round. You have to do 2 side port at 180 degree apart. Otherwise, you will have problems. So the side port has to be 180 degree apart. You can mark them as well. And this is the lens. Always examine under microscope that the claw is there, because there are sometimes manufactured defect where the claw is not there. It's almost done. So you insert the lens and then position the haptic where the side port is. This is a special forceps. There are several forceps which are available to hold the lens. You hold the lens quite firmly and just put the haptic, as you can see, put the haptic under the iris, and then take the side port and just tuck the clip in the iris. It's quite easy. Just press the optic against the side port instrument and it's tucked. Again, you change your hand, hold it with the left hand, push it under the iris, So as an anterior segment surgeon, I'm not venturing beyond the retropupillary space, tuck it, and that's done. So it's very simple, it's quite quick, and it's done quite quickly, and that's it. Then you can put, just make sure with triamcinolone, if there is any vitreous, do the vitrectomy if there is any, and I normally put some antibiotic in the intercameral antibiotic, and then I put air bubble and subconjunctival injection as well to complete the case. That's how I normally do my secondary IOL. And there are some cases of distorted pupil which you can manage with doing more numbers if you tuck them in the periphery. And there are some incidents of disenclavation which is reported about 3 to 0%. Only thing is that if you need to exchange, it's a bit difficult because you have to take it out by damaging the iris. Thank you.
Thank you, ma'am and sir, for the extensive presentation. Yeah, please, Dr. Sudiptam. Mic.
My voice is quite loud.
Yeah, now it's working.
Yeah, okay. So, Dr. Manisha, you showed us two different techniques of two different IOLs as well. So, do you have a strategy where to use which one? Do you have a specific?
The strategy is the surgeon. Like
Yeah.
I am very scared of actually the scleral fixated IOLs. I've broken a number of haptics. From the time the CT flex has come, I have totally given up the scleral fixated IOLs. So CT flex works very good in my hands. And the problem that I used to have of a lot of decentration in the previous technique, the scleral fixated ones, because it all depends on how beautiful you've tucked your haptics inside the scleral pockets. That has totally given, I mean, I don't face that problem any longer. The CT flex IOL, nothing seems to go wrong. Except when you are pulling it out, you should know that where you have to hold the haptics with the end gripping forceps when you are pulling it out. So I think it is just that what skill you have acquired. I don't think it's really going to depend so much on which patient is going to be chosen for which technique. I think it's the surgeon has to be comfortable with what technique.
Ma'am, I think the option of choosing comes if it is a traumatic case. Probably if their iris is already ruptured or damaged somewhere, then choosing may
that is going
sometimes
to be that is going to have an effect on both the techniques, I feel.
Yeah. Dr. Shalabh Sinha, sir, do you?
This is not now. The quiz is
Hello.
later, not now.
So, when I was seeing your cases, Dr. Manisha, I was wondering why you were not making the scleral pockets. And very correctly, Dr. Sugato, he showed that ideally you should make scleral pockets because those number of incisions, those number of sutures you have to place, and then the resulting astigmatism that the patient is going to have, it's better to make a scleral pocket. SICS.
So the reason for not making scleral pockets is because I don't know how to do SICS. I am an ECC trained person, and I am very comfortable in putting 10-0 with least astigmatism.
Yeah, but I
So
think you can.
Maybe
we
I'll
have-
come
we
for
have-
training to you.
No. No, we have all learned.
I
think
have a question
all
for
VR
you.
surgeons have learned.
How is
And-
the learning curve? Is there any incidence of tearing the haptics while pulling it out?
Yes,
Yes,
that happens. I was coming to that question. What if you tear? If you have asked for a lens, you don't get them in pairs. You just get one lens.
Right.
What if you break one
I
haptic?
agree totally. So initially, there is a learning curve for it, and that is why I told you the trick of the trade is that when you are going to be grasping the haptic, it has to be at the junction of the T, and it has to be in line with the direction of the haptic. If you are going to pull it like that, it is going to break up at the junction. So you have to be very careful. You have to spend a little few seconds to get your end gripping forceps in direction of the haptic, and then pull it out.
Thank you.
I want to share one thing. I went for a training for the secondary IOLs. There I went for this iris claw lenses, but the retina people, they don't love this. And they make me learn the ex-neat technique of scleral fixation IOLs. And the thing is, the first haptic, when we put it in the pocket, that was the very difficult learning curve. and I remember I did there 10 cases. So for the first 2 cases, I break 5 haptics. So it's very difficult. The haptic breaks mostly occurs when we try to pull the second haptic.
So the difference is that there the material is very, like it's a PMMA lens. So there when you are tucking it in, you break. I have also broken a number of them. That is another advantage I find with CT Flex. That's a soft material. So it is much easier to maneuver and you're less likely to break the haptic. The only thing you have to be careful is the direction of pull in that.
So if anybody wants to learn how to use the 3-piece intraocular lens for a scleral fixation, please start with a non-foldable one from Appasamy or from Orolab. The Prolene haptics are very thick and they don't break easily. The foldable IOLs of Orolab also, the haptics are thick, they don't break easily. If you're going to start with an Alcon type of lens, those haptics break very easily. In fact, it comes off from the optic also. So it's always better to start learning from the Indian IOLs because the strength of the haptic is much better than the Alcon or even the Technis or the Sensor 3-piece intraocular lens.
And I think initially it is a good idea to have a backup lens also.
Yes, always.
Yeah.
Otherwise, you don't know. And the case which you showed that the haptic was broken, I think you would have done cautery and got away with it. Just brought out that part and done cautery to that tip.
Maybe I didn't want to be a heroic person.
A beautiful discussion on this topic as the theme goes walking hand in hand, and a retinal surgeon with a pure cataract surgeon walking hand in hand with somebody like Salav who's a binocular. I would say both cataract and retinal surgeon. So that is what is the main essence of it. Oh, I cannot say all that unparliamentary words anyway.
I had a question.
So
Which
moving
one
on.
is more stable? So iris claw and
So I'm not a very big fan of iris claw lenses. I don't know, from the time the iris claw lenses got a bad name that causes the bullous keratopathy, that fear has not gone away as yet. So I would rather, yes, even if it's posterior fixated, the iris is always going to be, getting inflamed. Yes. So I'll tell you why it happens. If you're using the Yamane technique and when you cauterize and you push back the lens actually goes a little behind the iris, and there it does give you that. With the iris claw, it's going to shake like crazy, obviously.
Okay, so let us go on to the next presentation. So we have Dr. Anurag Mishra and Dr. Sudipta Mitra. They will be discussing about the ceremony of unfurling miniature apertures, managing the cramped pupils. So, Dr. Mishra.
Good afternoon, ladies and gentlemen. Let me get straight into business. I'll be speaking on managing small pupils without devices, and my partner Sudipta will come in to speak on how to manage them with the devices. Now, why do we want to manage our cataracts in small pupils without devices? The why of it. Devices, any pupillary stretching device you use, it always stretches the sphincter muscle, and therefore, postoperatively also the patient loses the aperture function of the pupil actually forever. It doesn't come back to normalcy or physiological state ever. And it's even more unacceptable, the pigment dispersion and the loss of aperture function in PCILs, so presbyopia correcting IOLs, be it an EDOF, be it a TRI. The how. The first thing, it's needless to mention, if you're not stretching the pupil and expanding it, some part of the technique, some part of the procedure is going to be blind. So the CCC, I would always recommend to practice this in normal cases. When we get trained, we talk about all centrifugal, centripetal forces. The The capsule is a piece of canvas. You have a paintbrush in your hand. Draw a circle on it. Don't think about dragging it back. Don't think about taking it to the periphery. Just draw a circle right at the center. 4.6 is my preferred size of rhexis right now, even with manual. So if you do that in normal cases, when you have a small pupil, you take half of the diameter of it, say around 2.3, it slightly lifts the iris, and as you go round, it keeps on tenting the iris at the pupillary margin ever so slightly, so you know exactly where you want to be. Some cases, however, you're stuck, and if you want to manage small pupils without any stretching device, what comes in really as a savior is your second instrument. So in the other hand, when you get stuck and you want to see the margin, take a Y hook, push the pupil to the periphery, see the margin, keep on changing the position of the Y hook so that you keep on seeing the uncut to cut junction, and keep on rotating the rhexis margin till it's complete. The hydro procedure again is partly blind, but when you take the cannula in, go rubbing with the nucleus so that you know you are essentially under the capsular flap when you liberate the fluid. It's essential that we do micro hydro at multiple places, and at the end of the hydro procedure, when you know that the AC is shallowing a bit, do rotate the nucleus. Once the nucleus starts rotating freely, 90% of your job is done. However, the crux of this is the nucleotomy. And once again, you depend on the second instrument, your savior, to come in to aid. When you chop, the second instrument goes against rubbing the nucleus again so that it stays in well below the capsular flap, and you don't engage the capsular flap while you drag it in to chop. It's my practice to rotate it 180 degrees, go to the opposite side, and complete the primary chop first before going into the secondary chops. Every time you chop, every time the chopper goes in, it should go very close to the nucleus so that you know that you are underneath the capsular rhexis. And every time there is a crack, look at the red glow that is peeping through, ensure that the crack is proper, so that finally when you cut down 6 pies, it is time for you to levitate one of those pieces and bring it out to the open for it to be consumed. All the while that the nuclear pies are being emulsified by you in the quad mode, the second instrument should stay right after the phaconeedle. The reason for that is when the nuclear piece is being used up or being absorbed or being emulsified, the moment there is a vacuum loss, since this pupillary margin is so close to it, the iris might just get sucked in. So to prevent that from happening, the second instrument stays just above the, ahead of the phaconeedle for that not to happen. It doesn't take too much of time, it doesn't take too much of energy, but yet what you essentially achieve is the aperture function being intact. The cortex cleanup, once again, you go to the periphery, catch hold of a cortical fragment, drag it to the middle, see what you're aspirating, and then you continue aspirating. The IOL implantation, the monofocal IOLs is not that difficult to implant, but what actually is the crux is aligning a toric IOL in case of a small pupil. So it's always my practice to put it into the bag completely, see where the dots are, drag it a little towards the center, see the IOL dots, and then try to align it along. Since I use an image guidance, things are a little more easier for me. But however, if you're not using an image guidance also, you can look at the IOL dots after dragging them little towards the center and then align it and leave them there. So these are the steps. Is it universal? Do I do it always? I do it particularly when I have an ATIL, but however, these are all just things that are commendations. Definitely no guidelines or rules can be passed to very esteemed and knowledgeable audience that's present out here. Thank you so much for your attention.
Audio डाल दीजिए please. That was a very encouraging video demonstration by Dr. Anurag Mishra, who's an excellent surgeon, and I keep on learning from Dr. Anurag's videos whenever I see him presenting. So, but sometimes, please put the audio on. Please put the audio on. What is somebody doing out there? So sometimes the pupil is really cramped, like uveitic pupils, and we have difficult roads to reach such beautiful destinations. So we may not be as it may not be such easy going with no instruments, rather with hooks and rings. So this was such a case, which was a very old patient, 80 years old, who was taking tamsulosin, and the pupil was not opening up with any agents, any drops or any intracameral agents. So we proceeded initially without any instruments. We went on. I would love if you can give the audio. There was a lot of lens matter, but below that was a hard cataract. My rhexis went small. This was the first step, which was difficult, and later on, as I tried chopping, there was a central leathery cataract. And slowly I could feel the pupil was going down until this state. So there was no other way out than to use some device, and age-old tested device is a hook. I usually use 4 hooks, which is dividing it to the all 360 degree, and until they are all inserted inside, we usually don't pull, so that there is no atonicity of the iris when we remove it. And the first thing that I did was a rhexis enlargement by cutting it at the edge with a micro-rhexis scissors, and then using a micro-rhexis forceps to enlarge it. This is much easier when you're using a device, as you don't have to fish below the iris. So, and with a brown cataract below, this was easy, but the next step was difficult. We thought of doing a multi-planar chop now, try to widen the chops that we earlier made, and finally reach the thick plate below. As you can see, this was a real hard cataract, and myself, to maintain the anterior chamber, I was using a lot of viscoelastics. We debulked the nucleus from the periphery before we reach the center. This also becomes easier if you use a device, because then you can stretch as much as required optimally. Controlled fluidics is one thing which we have to have when we are using hooks, otherwise there will be dislodgement of the hooks. And once this is done, things look easier. So I remove the hooks and put in the IOL in the bag. So this was the use of hooks as a device to open small pupil. Another case where this pupil went down very much with the IFIS, intraoperative floppy iris with a shallow anterior chamber, and what more than a beautiful ring. And this is a BHEX ring. There are many other rings available. There are no financial interests. And when you put a BHEX ring, the things look, it's a cakewalk, basically, because this does not widen the pupil more than that is required, and neither is there a lot of pressure on the pupillary margin. And you can finish your cataract surgery quite well with a ring like BHEX in place. And we did the same, and I used side instruments. I use a spatula always when I'm using a device to guide my phaco probe, or when I'm inserting any other instrument like the other device like an IOL implant. This helps me to prevent dislodgement of the device that I'm using to widen my pupil. So there goes in my IOL guided by my spatula, and I usually use a bimanual as I showed you in this video, and that's it. So using of devices is another way in unfurling cramped pupils. Thank you very much for patient hearing.
That is the discussion that will happen now. Can I ask Dr. Swaraj, sir? Yes.
The videos shown by Dr. Anurag and Dr. Sudipta both were beautiful, but to start with, little bit pre-thought must have to be put into, like putting NSAID's drug from the earlier number 1, number 2 intracameral adrenaline, and this situation. This also serves in a beautiful way, and then you come to the CCC. In that point of time, the attempt should be made to, you should make a habit of doing CCC up to the pupillary margin. If you are regularly doing like that, so you start practicing. Every surgeon is not like Anurag, but in that case, they will be touching the pupil and then all massacre will happen. But still, if you start practicing, you can do it. Secondly, once that point is okay, and in addition, putting the rings, iris hooks, everything is allowed. I think you should be liberal enough, without any ego, should think of using at any point when you feel it. It's not that, even I think in the toric IOL also, it can be given. BHEX ring can very well be given. Just taking care, because BHEX is such a sober ring, it doesn't make so much of big and all sphincter activity is lost, nothing like that. To some extent, it can be done.
I don't know whether this is the right kind of platform to speak of this, but the first thing that you said, the pharmacological agents, nothing works in a rigid pupil.
Yeah,
And the same goes true for BHEX. The same goes true for BHEX. Without mechanically stretching the pupil, the rigid pupils do not respond very well to BHEX.
In cases of BHEX, it is a flexible people.
That is the reason why it's very too malleable, too thin, too slender a device which doesn't have a lot of tensile strength. That's the reason why it doesn't work very well in rigid pupils. That's what I'm saying. You can use bulkier devices like the Malugan, like the Innova, like the Visitec iRing. These are all bulkier devices, but they work better in rigid pupils. The question here is, it's not about ego, definitely should not come in the way. Definitely not. But the thing is, whatever be the device, once you are touching the pupil to stretch it, the aperture function, the dynamism of the pupil gets affected, for sure. So if you have a PCIOL that goes in, I'm not talking about torics here, but the PCIOL goes in, which is, I'm not saying they're pupil dependent, but the pupil does play a role in controlling the amount of contrast loss and halos and glare and photic phenomenon, everything. So in the absence of a dynamism of the pupil, so wherever you can, you should. And where you can, only you can decide. Only the surgeon can decide.
It is not necessary.
I think that's the correct message. I think that's the correct message, that it's what works best in your hands. Because I think all of us who are cataract surgeons, I think the audience too agrees with us, that there are situations where after a few number of surgeries you can manage without any device. But sometimes it's like the case that I showed, I did not have any option than to use a hook or a BHEX. And not only BHEX, there are some other hooks as well, the Gupta ring and all. So can we have an audience, sir, can we have an audience poll on what type of rigid pupils? Yes.
There is a sphincter damage, no doubt about that, if you put any kind of device.
Any device.
Yes, of course.
There may not be any sphincter damage.
Yes.
If you put a device.
But what will you do if the pupil does not dilate?
There is some damage. So now the lens is coming into the refractive lenses, and these are all are pupil dependent. So if you have to achieve the skill
like Anurag. Yeah, Dr. Anurag. Yes.
In that scale, there are only
Sir.
So he's getting your mic, sir. He's getting mic. Sir?
Why do we have these devices?
I don't know. But the one thing that I would tell you is, if at all, if there is, so talking about the economy part, since a lot of these rings, particularly the Malugan and the Visitec iRing, these are the two rings that work the best, at least in my hands. And both of these cost 10K to us. So when I see that this patient might need the assistance of one of these two, I charge my patients for it. I'm very open about it.
Okay. Time tested.
It takes 2 minutes to put in 4 hooks and not even 2 minutes to take them out. So, I mean, I'm just wondering.
I have the role of iris hooks in my practice, I mean, that's the way I use it, is only when, as Sudipta showed, after the rhexis is performed, if it's an intrapupillary, mid-surgery pupillary phimosis, then I would consider the iris hooks. But electively, to start with, I don't use them. I don't use them.
Iris hooks, the tears are very uncontrolled.
Yeah, it's asymmetric too.
It's very
asymmetric.
Yes, and asymmetric. So even after doing the rhexis, I would rather go in and put in a so BX ring rather than putting the iris
I
hooks.
think if you open out the iris hooks really slowly,
Yes.
to the extent you want to open it out to, and
Yep.
in patients like complicated cataracts and very rigid pupils, it makes life a lot easier, I feel.
It
Just
does,
humble
but the
opinion.
tears are never in your control. That is the whole point.
Salaf, the point is what Dr. Anurag
I-
said.
I
Till the
guess.
time you try,
Sudipta,
that is what saying.
Sudipta, quick point, sorry. The technique of putting BX after the rexis is different from putting it before the rexis. If you are putting it after the rexis, don't just leave it. You have to actually tend
Lift
the iris up.
yes, tend the iris up.
Go and
depends on
make
your
sure
visibility.
that the rexis is visible, then leave. Just don't put it, then you'll catch the rexis.
Yes, of course.
Yes.
Yeah.
I mean,
No, but
technically
it has
more
corners,
difficult. It technically
Shugato,
more
it has
difficult.
corners, so even when you are dislodging it, if it just captures one segment of the pupil, it's not.
Anurag, I'll tell you, it's quite my first case after rexis. I caught the rexis, but
See, with the rexis being there, you can even put the Malugan. Same technique by tenting and
By
putting in
tenting and lifting
viscoelastic
the
and
iris,
creating
you
a
can
space.
put it below
That's not
the-
the point. The point is, it's not.
No,
Nothing
I
is
could
as
see
safe
the
as the
rexis.
iris hook after you've done the
Visibility
rexis.
was there. Anyway, I think we've got a very good discussion, and again I salute Dr. Anurag Mishra for his technique,
Come on.
and of course our beautiful inputs from all of us. We move on to our next topic by two more experts, Dr. Suvira Jain and Dr. Arup Bhaumik, and the topic is restoring bag stability in a case of subluxated IOL. All over to you, Dr. Suvira.
Thank you. कहाँ है? मेरा आपके इसमें है. I'll have the music, huh? इस पे बात करूं कि इस पे? दोनों पे. आज का ये जो सेशन है आज का सेशन 3 o'clock 3:32. This is one. This is, it's not in this. मेरा सेशन 3 to 4:30 है ना? ये सेशन नहीं दिख रहा है इस पे. It's just going to take a minute. They're trying to find it. I've loaded it on. अभी का सेशन 3 to 4:30. ये. Yeah. Okay. We have
Dr.
to make
Arup, are
music.
you ready with your presentation?
No, I've got it now.
Oh.
They found
No,
it.
please
now.
go ahead.
You are ready?
Yes, I
Okay.
am. Suvira Jain. Yep. Okay. Relax. ये ऑन कर देंगे. They are playing it. ना अरे आप ये 3 to 4:30 सबसे ऊपर का. Yeah. Thank you. Okay. Play करिए.
The speakers, if are not ready, then the quiz masters will take over.
No, stop. Go back.
That's running actually.
Yeah. Okay. Music, please. Let's discuss the strategies in the management or the regaining of capsular bag stability in patients with sonlar dialysis. So preoperative sonlar dialysis, you can actually evaluate and work out the patients. This patient was a patient with a young trauma of 10 years duration, but since the rest of the zonules are okay, a CTR placed with a hand-on-hand maneuver in the capsular bag gave me adequate equatorial stability. The very soft nucleus was hydroprolapsed out of the eye, the cataract aspirated. At any point when the source of irrigation comes out of the eye, we do a viscofluid exchange. And my technique of attaining pseudophakia in cases like this is the implantation of a 3-piece IOL in the ciliary sulcus, and as you can see, a posterior optic capture. And when you're removing the visco, you've got to be careful and mindful that you don't end up releasing the capture. Now, creating a capsular rhexis in patients with subluxation is imperative, sometimes difficult. This is a patient with an absorbed cataract with loss of zonules. And here again, you've got to be very careful that you center it in the center of the nucleus, not of the rhexis, and keep at least a 2 millimeter gap. In a patient with a generalized zonulopathy, just the initiation of the rhexis can be a challenge because of the lack of the contralateral zonular pull. You may need to be able to pull on the rhexis in either direction and look at the folds in the anterior capsule whilst completing it. So also this is another patient with a good red glow. You're able to see with a gross zonular loss. You often need forceps, but this surgeon with the help of a cystotome has managed it. Intraoperative zonular dialysis, here are a few such cases. These are unplanned and leave you questioning how bad is the dialysis. Here, look, while just pushing the optic in, there's a large zonular dialysis. Now, in a case like this, mere rotation of the IOL to keep the haptic against the area of the dialysis may work. This is performed, SICS performed by my colleague, while trying to attempt to remove the cortex inferiorly, as you can see here. As soon as the Simcoe comes out of the eye, there's an inferior zonular dialysis. Once more, because of this tiny ZD, just the mere rotation of a rigid IOL so as to achieve the haptic against the area of the dialysis should work. In this case, towards the end of the nucleus management, you could see a zonular dialysis, and here you can see while putting in visco, it got worse. So what do you do here? The surgeon actually implants the CTR, and with the help of a Sinski hook, the trailing eyelet in the eye, but clearly there's a vitreous disturbance. In this case, with the help of a repositor, it's reposited in, and that stand was just cut with the help of scissors, achieving a good end result. Irrigation aspiration, also an important cause of accidentally holding onto the equator, resulting in a large zonular dialysis. When you have a situation like this, a viscofluid exchange is very important, and a CTR is introduced with a hand-on-hand maneuver and rotated into the eye to achieve the equatorial stability of the bag, after which an IOL can be implanted in the capsular bag. Here, nothing was known. Once both the instruments come out of the eye, the surgeon actually notices an inferior displacement suggestive of a zonular dialysis. When we use a CTR, we have to make sure that the rigid part of the CTR, the one without the holes, is in the area of the zonular dialysis. And sometimes you may need to use capsular hooks, like in a case like this. A fairly 4 clock hour zonular dialysis, managed a well-centered small rhexis, but even before putting in a CTR, I put in these hooks. They are made from Madhu instruments. They go up to the equator and achieve a vertical stability and equatorial stability of the bag, which is then added on with more support by the introduction of a CTR. Once you've got the bag stabilized and supported, then a hydrodissection and aspiration of the nucleus, followed by the aspiration of the epinucleus. And you leave the hooks in place till you're doing all of the above. Again, viscofluid exchange at all times. In this case, then I remove all the epinucleus, followed by the removal of the cortex. And then the question is, at what point do I remove these hooks? But I want the stability of the capsular bag with both the devices. The CTR is going to remain in there. And as I told you, I always attempt a 3-piece IOL implantation with a posterior optic capture. Just after introduction of the optic, I remove the hooks and then perform a posterior optic capture. I wondered here whether I should have actually fixated the bag, but even in the post-operative period, I had a fairly centralized, well-centered IOL. Patient had a vision of 6/9 and did quite well. Thank you.
Thank you. Can I have the presentation? So, thank you, Suvira. I'll talk about the second part of the managing subluxation. This is a long-term cap fixation of the capsular bag. So, this is the video which I started many years back. That time, 90 Polin is available only one straight needle or one curved needle. So, it don't have a two straight needle in that sense. So, it's a extremely subluxated cataract. You can see this. I just release the capsular hook to release the creating the space in between, and guided the straight needle into to the main port, and come out with this, and this main port just make a knot to the C tier segment. There's a Ahmed segment. I always prefer to the combination of both, that there's a CTR and the Ahmed segment rather than the Sioni ring. There is a lot of logic, but I do use Sioni ring where there is a less fornix. We're not able to make a fornix of 2 millimeter from the jonular from the equator. That different discussion. So I make it not here and put this segment into the capsular fornix and and make a multiple throw. Don't try to tight on multiple throw and then tighten. You no need to give a knot there. Just tighten as per your requirement and implant the lens into the back. So next part is, now this scenario India is changing. You have a 90 Prolene with the 2 straight needle. So I started doing the Hopman pocket. Now this is a standard technique of doing Hopman technique to make a corneal, real corneal incision. I just little bit fast forwarding this case and dissect the towards the sclera. And why you dissect the chlora? You just mark your bed so that you can pass easily the to needle. You can see the your needle. You can use the pen, marking pen, to mark the bed of the your Hopman pocket. So this is a standard. Even you can put some trypan blue into the pocket base, and I have started the cataract surgery. And the same technique, now we have a 9-0 Prolene with the 2 straight needle. So this is a standard technique, rail load technique. I floor from the roof of the tunnel, and this just I'm a little bit fast forwarding this again. Make a into the pass the needle through the Ahmed segment eyelet and pass the needle again from that side, and how you fix the CTR segment. Now you just put this again CTR fast, then followed by the CTR segment, and pull the suture from the base of that Hopman pocket, cut the roof and put the IOL fast before tightening the Ahmed segment. So and now I am tightening the segment as per, you can observe the lens whether the lens is center or not. So and now put the knot onto the turn. This is the standard technique, and I just this is my first case of, now I am doing the Gore-Tex suture to permanent fixation. Okay, I'll just finishing in the Gore-Tex suture, because now Gore-Tex suture is readily available in Indian market. One vendor from the Mumbai is supplying this, but it is costly. One pack is 78,000. It is 10 suture, so every suture came at around 10. 8 to 10,000. So it is partly, but you can YouTube and you can use the Gore-Tex suture 2 to 3 times. So but you have to bring the Gore-Tex suture to the forceps. You need to have a very good forceps for that. So Ahmed, IK Ahmed is a special forceps for this Ahmed segment, but I don't have that forceps, but I using the 23 gauge engraving forceps. So again, in case of Gore-Tex suture, the 2 parts per I make a in between two puncture. I make a little bit of scleral tunnel so that I can bury the thick Gore-Tex knot into the, you can say, just I want to show the last part because this is very important, because the knot of the Gore-Tex suture is very thick. It can erode your conjunctiva. So just cut it and pull it into the tunnel. So this is the that is the technique. You just pull into the scleral tunnel. The end of the surgery. Thank you so much.
Thank you, Dr. Jain and Dr. Bhaumik, for the presentation. Can we have comments from Dr. Shalabh Sinha and Dr. Swaraj also, if there's any?
Yes, so Dr. Bhaumik actually showed the larger area of zonular dehiscence, or the, where you actually require the bag to be stabilized properly with the IMET segment and the CTR. And of course, the Hoffman pocket has made life much easier. But again, as he showed very correctly, whenever you fashion a Hoffman pocket, make sure that it is wide enough. Otherwise, your two sutures that will come out will be very close to each other. And I've had cases where when I'm tightening it, it just cuts through, because there's very little space between the two sutures. So that was very well brought out by Dr. Arup. And of course, Dr. Suvira, your case is, relatively simpler zonular dehiscence, which could have been managed without doing all these heroic things.
Yes, that was my topic.
But the last case actually required it to be fixed with a armor
I thought
segment.
about that, yeah, and then
Yes.
it happened, and then I said, let me see, this lens is looking pretty centered. I also did a night trace on this patient the next day to look for decentration. There
So
were no
was it a
aberrations.
traumatic dehiscence, the last
first
one?
The last was also, trauma in a young patient.
Okay. So we must remember, yes.
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 So that is what I was coming to. In the traumatic zonular dehiscence, you may get away with just putting in your CTR, but if it's a progressive type of zonulopathy, then you need to fix
definitely
it,
need to fix it.
and you would need 9-0 and Gore-Tex rather than 10-0.
On the premium practice, even the smaller jonular dehiscence, if you want to put this new generation IOL, that then you have to fix the bag, because your lens has to be
Has to be
Well centered.
very, very stable.
If you want to put the spherical lens, it's okay. Little bit of decentration will not cause any problem.
Yes.
But
And
even if it's a 2-3 clock hours zonular dialysis, young, trauma, 3/4 of the zonules are okay, you'd still want to fixate those bags?
But if you want to put immediately, you have to fix
He's talking about the premium IOLs.
Yes.
Yes.
Yeah.
Yeah.
Sure.
And the other change that I've made in my practice is,
And a late decentration, yeah.
So we are
Smart
running
point.
short of time. We have
yeah,
to
one
leave the
one
hall.
more point I wanted to make out, that if you're putting in CTRs very regularly, you may get away with just pushing it hand to hand as she showed. But please, if you can acquire the injector, it's much more controlled than doing it with the hand to hand. You just put it in the first eyelet of the CTR that comes out, just hook it with the Sinsky. The pressure on the remaining zonules comes down drastically. So if you can do that, that will be much more.
Hence it.
Yes, exactly.
Come forward.
Opposite to it. Yes.
ঠিক আছে আনসার করে দেবে নিয়ে চলে যাবে তুই পাবি না
Come in front.
The epsilon is good. Yes, I have the epsilon one. It's good. Yes. Yes, but even the Gupta one, even the Gupta ring that has come,
সুদীপ্তা
it is based on your, what you showed 10 years ago, the 1cc syringe. It is just like that. Have you
Okay,
seen
we
it?
can have this talk continuing among experts,
we have to
but
leave the
we
hall.
have to complete this session since, and the most interesting part of this session is the audience quiz with the voting pads. I am sure everybody has got the voting pads, and all over to Dr.
Yeah.
Shugato Pal.
So we'll start very
So
quickly.
you have all, everybody has a, please collect from
voting
behind.
pad, voting pad, quickly.
Please collect your voting pads.
No, you have to start and finish in 5 seconds. No.
All done? Okay. All over to you. Shugato, just
Yeah.
tell the rules.
So, no rules, just place A, B, C, D as the choice which we'll be showing, and then we'll go to the next question. So the first question, If we are ready, identify this person. Very, very easy question. Identify this person. Hermann Helmons, von Graffe, Alvar Gulstad, and Jacques Devielle. Yes, yes. So, yeah, I'm counting. Yeah? হ্যাঁ প্রেস করে দেওয়া হ্যাঁ করে দাও করে দাও yeah so the answer is Alvar Gulstad. He was the only person ophthalmologist who got the Nobel Prize, and also he stopped Albert Einstein to get the prize at one point. So next question, Duriasta, which incorporates a pellet of bimatoprost, is injected where? Upper eyelid, subtarsal conjunctiva, intercameral, and upper canaliculus. Time starts now. Okay, so the answer is intercameral. Can I see the script? Yeah. So how many got this right? नहीं दिखाई दे रहा? Okay, so next question. This is a 46-year-old female with poorly 46-year-old female with poorly controlled diabetic, has bilateral retinal changes. What is the management? You can see the changes there. Some leakage, you can see the OCT, you can see the DFA, you can see some blurring temporal to the fovea. For a poorly controlled diabetic, bilateral changes, and the time starts now. Okay, so who has answered C? No one? So the answer is A, observation. So this is actually not a diabetic changes. These are what? So next question, Vox tria in glaucoma, all are true except segmental iris atrophy, pigment dispersion, milky deposit over the lens surface, and glaucoma flecken are caused by lens epithelial cell necrosis. Time starts now. So answer is C, where the milky deposit are caused below the lens surface, not over. And the last question, again a 65-year-old male, anterior segment and gonioscopy findings are shown here. And the IOP is 29 millimeter of mercury. What is the first line of treatment in this patient? See the picture. What is the management? Anti-glaucoma drops, laser trabeculoplasty, intercameral anti-VEGF followed by PRP laser, and the last choice is trabeculectomy. Time starts now. So the answer is anti-glaucoma drops, and I think only 6 has got this right. This is, you can see the pseudo exfoliation and the deposit of pseudo exfoliation particle in the angle. So there is no NVI or anything in the angle. So not anti-cameral, intercameral anti-VEGF. The answer is glaucoma drops. That's bring to the end. Can we have the leaderboard, please? The winner, we need to see the winner. And student 551. So Dr. Chakravarti is the president of OSWB. I was thinking of calling you to give the prize away. So I request no second prize. No one remembered the second one. Actai prize. Is the fastest singer first? Yeah.
This is my great honor to give such a person.
Here, তোর কোটে রাইট হলো ভালো দিলেন তো